Hello to our fellow hospital administrators. Today the team of Sophie, Casey, Caleb, and Anna will be presenting to you all on our hospital's plan to improve Roma health outcomes. To begin, I will give a brief introduction to the Roma people in Poland to orient us to the need for this intervention. A history of systemic oppression, discrimination, and violence against the Roma people is long and widespread, existing long before the creation of Poland in 1918. During World War II, tens of thousands of Roma people from across Nazi-occupied Europe were killed at Auschwitz-Birkenau in Poland, contributing to the estimated 250 to 500,000 Roma killed during the Holocaust. Roma people were largely left out of restitution or support after World War II due to claims that any persecution by the Nazis was a just result of crimes of the Roma people. In addition, the 1980s saw forced settlement of mainly nomadic Roma communities, as well as forced exile out of the country. More recently, the Roma people in Poland are impacted greatly by systemic and interpersonal discrimination, socioeconomic exclusion, and hate crimes. The impact of this discrimination can be seen through the unemployment rate that is over 2 times that of non-Roma people, high levels of forced evictions, and housing that is overcrowded, low quality, and often unsafe. The social conditions in which the Roma people live in Poland contribute to disproportionately poorer health compared to non-Roma Poles. Throughout this extensive discrimination, the Roma people have resisted forced assimilation and have held on to their culture as much as possible. An estimated 50,000 Roma people in Poland. 13% of Roma in Poland live in the region to which Krakow belongs, totaling approximately 6,500 Roma people in the geographic region of our hospital. In this region, the majority are Bergitka Roma, who are the only Roma subgroup that have been mostly sedentary since the 1700s and today are the most at-risk Roma group in Poland. With these low population numbers compared to the wider population, less than 1% of the population in this region, quantitative data on Roma health is rare. Nevertheless, the literature is convincing that large-scale radical changes are needed to address the root of these issues. We recognize that these interventions are far from comprehensive solutions to the extensive issues facing the Roma people. Within our position as administrators at the University of Krakow Hospital, our scope of influence is within the hospital's resources and setting, so the rest of this presentation will discuss hospital-based interventions for the benefit of Roma health and the hospital at large. The context of COVID-19 has exacerbated existing gaps in health, and though the data is not disaggregated, we can assume a disproportionately worse impact on the Roma people in Krakow. These interventions are to improve Roma health data collection and availability to ensure we can understand and address barriers to well-being as efficiently and effectively as possible. Second, we want to be able to submit a strong report to the EU Commission that showcases our intervention plan and evaluation tactics in order to maintain our spot as a top-tier hospital in the country and an example of hospital management and innovation in the EU. Along with the official documentation of the intervention, achieving a good return on investment will allow us as a hospital to continue operating at maximum efficiency, continuing to lead our peers in research, teaching, and saving lives. Lastly, the overarching goal of our intervention is to address the determinants of health of the Roma population in our area, promoting equitable health access and outcomes through investment into health initiatives. The goals we've laid out, we will focus on 4 key areas. First, we will prioritize community representation and input, which is especially important for the Roma community, which has been historically silenced and excluded from discussion about their own lives and well-being. Next, we'll utilize the community input to address the hospital setting and experience, making it appropriate to the needs of the Roma community. Our hospital will also work to bridge the existing gap between the community setting and the hospital setting, reducing the barriers to seeking preventive and primary care. Lastly, we will employ intentional data collection to track the success of these interventions, inform future health programs, and prove effectiveness to our national government and the EU Commission.
The following framework describes how our interventions reduce health disparities for the Roma community. Each color represents a different intervention, and any intervention outlined in dark blue indicates that data collection will occur at this step. Our first intervention is a community advisory board, indicated in yellow, that will be used to inform all other interventions. The rest of the interventions will then occur in 2 main settings, in the hospital and in the community. In the hospital setting, we will have 2 interventions. The first indicated in light blue, is a cultural education and training opportunity for healthcare providers, and the second, indicated in red, is our community health worker in the hospital program, which has a community representative attend appointments with community members. In the community setting, we will have one intervention, indicated in green, the community health worker in the community program, and this will be used for various activities to promote healthy behaviors, increase healthcare utilization, and provide primary care. In the end, all interventions, data collection, evaluation, and quality improvement will contribute to the overarching goal of reducing disparities in the Roma population. Our first intervention is based off the Health, Research, and Educational Trusts Creating Effective Hospital-Community Partnerships to Build a Culture of Health tool. For this intervention, we will form a community advisory board made up of leaders from various backgrounds in the Roma community to ensure we hear from all perspectives and voices. The board will inform all additional interventions, assist in quality improvement of interventions, and provide information regarding the needs of the Roma community. Through these tasks, the board will aid in producing culturally competent interventions and addressing health concerns that members of the Roma community have. Overall, the Community Advisory Board contributes to building trust between the healthcare providers and the Roma community and gives power and agency to the Roma community.
In order to foster a healthcare environment that is welcoming to all individuals, including the Roma population, and a space where Roma individuals feel respected in their identities, we are proposing a hospital-based intervention of education and training for all employees. This training will incorporate principles of cultural connectedness, a concept based on an approach developed by the Population Health Promotion Team of BC Women's Hospital in British Columbia, Canada. The core premise of the program is an approach that helps healthcare providers and their patients to develop a shared understanding of each other's values, beliefs, needs, and priorities. Additions to the approach will be made to include Roma healthcare facility-specific spiritual beliefs, including cleanliness practices, the importance of respecting familial structures for the community, and Roma beliefs around gender roles and preferences. For instance, cleanliness is very important, with traditional Roma following certain rules in the way they cook their food, keep their houses, and tend to their bodies. The upper body, including the head and mouth, is generally considered clean, whereas the lower body is considered polluted in a spiritual way. These beliefs lead Roma to consider hospitals inherently polluted because the people working there do not understand or follow the same practices. Additionally, familial structure is very important for providers to consider. When reporting the patient's condition or obtaining medical histories, it is advisable for clinicians to consult primarily with esteemed older family members, generally men, who make the family decisions. Training materials will be informed by the Community Advisory Board and will be required for individuals who are directly involved in patient care, including physicians and nursing staff, and will also be made available to all other hospital staff as a voluntary educational opportunity. Administrative and board member staff would be highly encouraged to take part in order to strengthen their knowledge about the specific needs of the Roma community. To better serve the healthcare needs of the Roma population through the full spectrum of the healthcare continuum and improve health outcomes related to hospital services, community health workers will be hired as hospital employees to serve the Roma-specific patient base. Community health workers are flexible and multifaceted, patient-driven and cost-effective, lay health workers with a scope of practice different from what is typically seen in a hospital. In this intervention, the community health workers will be individuals from the Roma community who are hired as hospital employees to function both within hospital walls and out into the community where the Roma people live, work, worship, and play. Within the hospital, the community health workers will serve in multiple capacities, with the primary responsibility being accompanying individuals to appointments and assisting them with the navigation of the healthcare system. They will also work to facilitate communication between patients, their families, and providers to reduce barriers to understanding treatment for patients themselves and increase knowledge within the family unit. This communication strategy will work to accommodate the Roma practice of sharing health information widely with their greater family. Informing patients' families directly on the needs of patients will help to facilitate understanding of the healthcare needs of individuals seeking care and also increase the support they receive from family members. Finally, the community health workers will serve as subject matter experts on the Roma community by sharing their lived experiences within the hospital system. Their personal knowledge and shared lived experiences as members of the local Roma community will help to inform practices within the hospital and inform decisions being made by individuals in positions of power that impact the delivery of care. In the community setting, community health workers will work to address and remove barriers to healthcare access for the Roma community, provide culturally relevant health education, and most importantly, improve trust of the Roma community in the healthcare system, among others. Additionally, community health workers will facilitate and carry out data collection to assist in the needs assessment and identification of areas for improvement in healthcare delivery. As members of the Roma community, community health workers will be able to relate to community members' lived experiences, which may lead community members to disclose information or data they may not otherwise be comfortable sharing with outsiders to their community.
The next piece of our intervention is collecting and evaluating data. Data collection will follow the two-pronged approach seen with the community health workers, and the data found will be used to inform both the health status of the Roma people, as well as the later evaluation of programs. When thinking about data collection, it is really important to utilize the community health workers as much as possible, as Roma people often avoid stating ethnicity due to the years of racism and discrimination. In addition, it's important that at both of these settings, data collection processes are thoroughly discussed with the individual, explaining the benefits as well as what exactly will be done with the data. At the hospital, the data collection will be done by the provider with the presence and assistance of the community health worker. The data on this side will focus on health-related data, including various health conditions, health metrics, and vaccination status. After the appointment, evaluation will be completed through a survey focusing on satisfaction with care as well as cultural competence of the provider. In the community setting, data collection will be done by the community health worker, and it will focus on demographic information as well as a needs assessment. Evaluation will also be done on this end, including using qualitative data on community needs as well as satisfaction with programming. Overall, the yearly cost of the program is estimated to be about $155,000. This includes paying 6 community health workers the average salary in Krakow, paying a trained data and program evaluator, as well as administrative costs. Looking at past research on community health worker programs, an estimated $2,245 is saved per patient, and hospitals can see a roughly $2.28 return for every dollar it puts into these programs. Using these savings, only 70 participants would be needed to fully fund the program. With an estimated Roma population of 6,500 in the region, we think this is very doable. In addition, money could be brought into the hospital through already existing EU-based funding programs for Roma health interventions. Another important aspect of using community health workers is the potential benefit for other hospital investments. The background research we did on the Roma community showed that social networks are very important, and information on trusted providers is spread frequently through word of mouth. Once a trusted member of the community finds a provider they like, more members of the community will go to them. This increase in patients will in turn increase hospital revenue, further offsetting the cost of the program. In addition, as community health workers help build trust in the Roma community, the Roma people will hopefully become more involved in other hospital initiatives. For example, the WHO found that in countries where community health workers were utilized, vaccination investments were much more cost-effective. Specifically in Ecuador, hospitals that used community health workers to build trust and educate the population had a cost of $32 per immunized child, compared to $778 when community health workers were not used. Using this community health worker program will not only be beneficial to the community, but will help build trust and expand hospital return on investment.
In the end, our proposed interventions will be used to improve health behaviors, primary care, trust, and healthcare utilization, which in turn will reduce health disparities and discrimination for the Roma community. Our proposal is ideal because it is feasible in the scope of a hospital, it invites the Roma community into a position of power, it provides economic benefits and returns to the hospital, and it establishes a sustainable, holistic framework that has the ability to address multiple health behaviors and problems depending on what the community needs throughout the years.